So today's basic discussion would be on hormone receptor positive metastatic breast cancer. So if you look at it, I'd just like to know, Shrilesh, what is the percentage of hormone responsive positive breast cancer you see in your
Good,
practice?
good evening, sir. So basically, it is around 50 to 60% the metastatic setting.
Okay, Santosh, is that the same with you?
Yes, sir. I think I would agree with Dr. Shrilesh.
Yeah, I think one of the papers published from Bangalore, Kidwai Center, shows that the overall hormone response positivity in Indian population is around 40 to 50%. So just coming to a case, a young lady, mother of two with back pain since 2 months, comes and wheeled in a wheelchair, and bone scan shows extensive metastasis. PET CT shows a right breast lesion, multiple bone mets, and 5 liver lesions. Liver functions are normal. Biopsy is IDC grade 3, ER positive, PR positive, HER2 negative, and Ki67 40%. Aditya, your thoughts on such a patient?
So young premenopausal lady with disease bulk, but not in the actual definition of a visceral crisis. So in a way, maybe chemotherapy could be discussed, but also given the recent data that we have with CDK4s, combination of hormone with ovarian suppression and CDK4. So both of them are valid options. Maybe a few years back, 4-5 years back, I would have said definitely chemo. But given the fact that she is young and we may want to save some lines for later, I would want to probably start with hormone, ovarian suppression and CDK4.
Fair enough. Karthik, in Manipal, what do you do with such a patient?
I think this is an ulcerated breast lesion who has come on a wheelchair. I don't know, maybe I am a little old-fashioned, but I would like to go with chemotherapy, yes. I'm more comfortable that way.
Not old, yeah. Suman, a young person from Chennai, what is your thoughts? Suman, are you there?
Hello.
Yes, Suman. I think we'll get back to Suman later on. So like how there is a thought process of using chemotherapy in such young patients with such a bad disease. But I think this was the same thought process. If you look at this consensus recommendations, just I think 3-4 years back in 2018, you can see that most of the medical oncologists in India would have used chemotherapy upfront. I think Karthik was definitely part of this. So however, the things are changing, and we know now that endocrine therapy versus chemotherapy, there are multiple studies, there are multiple publications, and it is now pretty clear that there is no chemotherapy regimen with or without targeted therapy, which is better than CDK4/6 inhibitor plus hormonal therapy in terms of response rate as well as in terms of progression-free survival. Shrilesh, is this your thought process, or would you think that chemo would be the first thing?
No, sir. My choice would be hormonal manipulation only, sir. Chemo, I will, for a frail lady coming in wheelchair, I think I would prefer hormonal manipulation rather than chemotherapy.
Okay. Suman, I think I can see you there. So you are the youngest one among us. What would you think?
So, the same. I think I'll go with CDK4 inhibitors with ovarian suppression and reserve chemotherapy. Though the knee-jerk reaction will be to start with chemo, I would resist that given the new data. So I'll start with CDK4 and ovarian suppression, and then keep chemotherapy maybe for later line.
Yeah, so I think in general, I think 4 out of the 5 panelists would go with a combination of CDK4 inhibitor plus AI. Dr. Karthik would go with chemotherapy upfront. Having said this, it is pretty clear in the same meta-analysis which I've showed you now. It was very clear that if you're not able to afford a CDK4 inhibitor, or for some reason CDK4 inhibitor is not given, then probably it is better off that you start with chemotherapy and then take up the patient for hormonal therapy in such patients. So even if this patient is in visceral crisis, Santosh, even if you have a patient with visceral crisis, imagine this patient's bilirubin is 1.8, bordering now. What would your thought process be? Now, there are papers like this one from China saying that some experience with using this combination even in patients with visceral crisis.
Sir, the degree of visceral crisis varies from patient to patient. If it is like a really desperate situation, maybe I would try to tilt towards chemo, but as much as possible, I use the combination of AI or fulvestrant with CDK4/6 inhibitors.
Aditya, what is your thought process? The same lady now has bilirubin of 2.
No, but in this, I think I would like to agree with Karthik sir a little bit, because young lady, we don't know how much time we have to try and salvage her. The thought process of saving chemo for later lines may not be in question here. There is data, even new data suggests that in visceral crisis you would want to use, but 29-year-old lady, I would take chance and give some chemo. Here, though, it is very hard to refuse chemo here.
Fair enough. Fair enough. So, Suman, you have chosen, hormonal therapy with AI, and we now know that among hormonal therapy, probably fulvestrant has got some benefit, especially in patients without visceral disease, according to this Falcon. Now, based on this Falcon trial, which hormonal partner would you combine with CDK4 inhibitor?
Ideally, since she's premenopausal, I will not risk using letrozole. I just go with fulvestrant along with CDK.
Fair enough. Karthik, imagine your option of chemotherapy was not allowed and you're going to start CDK4 inhibitor with hormonal therapy. What would you do?
Yeah, I think letrozole with CDK is a good option here.
Okay, and of course you would add OFS.
Yeah, along with ovarian suppression, yes.
Fair enough. Srilesh, what about you? Are you concerned that fulvestrant is a better drug?
No, sir, I will reserve fulvestrant for second line only. I will usually, my personal preference is always letrozole with ovarian function suppression along with CDK4/6 inhibitors.
Okay. Santosh, regarding the Parsifal trial, which actually showed that whether you give fulvestrant or letrozole with palbociclib, there is hardly any difference. In fact, in a patient like this who has got some lesions in the liver, probably it would be better off with using AI. What is your thought process on this Parsifal trial?
Yeah, I mean, there's a good trial to look at when deciding between fulvestrant and AI. However, there is additional data that patients who get fulvestrant do probably better if they had bone only metastasis, and somebody who is like typical metastatic hormone receptor positive breast cancer who has bone only metastasis, I tend to use a combination of fulvestrant upfront. Otherwise, would tend to go with the anastrozole letrozole combination with CDK4/6 inhibitor, just mainly because of convenience sake.
Fair enough. Aditya, imagine this patient has come to you. You have given her 6 cycles of taxane. Now, what plan is yours? Would you give her CDK4 inhibitor with AI, or what would you do?
Ovarian suppression, AI, and CDK4. I do agree with all my other panelists, because it is convenient to use oral letrozole. I've already called her back to the hospital 6 times to give chemo. Don't want to call her back again monthly to give fulvestrant. So maybe reserve fulvestrant for a little later and give letros ovarian suppression with CDK.
Fair enough, yeah. So, Suman, your thoughts on treating such a young lady? What are the challenges you think?
Challenges, of course, is resistance itself. So ERS, generally it happens within 6 months, 8 months, so just months time until we had these CDK4 inhibitors. Now we talk about years, at least a year before she comes back with some progression somewhere. So that's the first problem. Other than that, most of the premenopausal patients are quite compliant with therapy, so they do come. So once you offer, that's why I go with fulvestrant. Well, compliance is good actually with fulvestrant. If you give one injection, You do surgery, you give an injection, and then you give tablets. I think the compliance is more. This just my point.
Fair enough, Suman. And I'm sure I worked in Tamil Nadu. People love UCs there. So they love injections. So, Shrilesh, your thoughts on this young age at diagnosis? What is your thoughts on such patients?
So young breast cancer is considered as a very aggressive, sir. So when I passed my DM, so we tend to use chemotherapy for young patients who are hormone receptor positive. But nowadays, because of this, we have this Mona Lisa 7 and all these trials. We are very confident that hormonal will do as good as, even more good than chemotherapy. So I think even if they are aggressive, but just by menopausal status and that aggressiveness has gone now. So.
Fair enough. But we generally know that such young patients have got a very high risk of relapse and death. They're pretty symptomatic, and the quality of life is very low compared to older patients because they are inherently much more active people and a lot more responsibilities too. So, do you think overall survival is extremely important, Karthik, in your patient with advanced breast cancer?
Yeah, I mean, because definitely it is very important because here we are not talking about PFS. This is a young patient, so we have to tell about how long the patient lives. So definitely overall survival is a very important landmark here.
Okay. So Santosh, this Mona Lisa 7 trial, just the updated results which are published. Can you just throw some light on this, regarding the overall survival?
Yeah, it was done in the premenopausal age group or the perimenopausal age group, where a combination of ovarian suppression and the ribociclib and aromatase inhibitor or tamoxifen was used, and they found improvement in PFS and OS that was significantly better than the placebo-controlled arm. And is one of the few studies which has shown OS benefit compared to the other competitors that these molecules have.
Aditya, your thoughts on this? I think even 48 months with the AI and placebo is excellent. 4 years for a young lady like this.
Correct. So essentially, when we were training, we used to look at PFS as the endpoint for metastatic chemotherapy trials. It is quite refreshing that we have OS as an endpoint for any metastatic cancer trial. And as Karthik sir said, OS is the reason why we all have our job. So the actual OS data does sort of reaffirm our choice in using a particular CDK. So having an OS data definitely does make me that much more confident in picking a CDK4 over B CDK4.
So I think in other words, apart from the overall survival, we see quite a good quality of life with these younger patients. And whether it is in such young patients in the Mona Lisa 7 trial or the Mona Lisa 2 and 3, mainly the postmenopausal women, we see overall survival benefit. In fact, the time to chemotherapy is also significantly prolonged with the ribociclib, and the overall health status is also excellent. So there are two updates which we have seen. We have seen the Mona Lisa 7 update. The Mona Lisa 3 update, which was published last year, showed an excellent benefit, 31.1% versus 46% at 5 years. And Suman, your thoughts on this Mona Lisa 3, wherein also they said that even patients with more than 3 metastatic sites, liver, lung, those bad diseases also significantly benefited with ribo.
Yeah, I do go with them because in the trial, if you see the response to treatment is as early as 6 weeks. So given that the term of visceral crisis is going away day by day, so now we have visceral disease and visceral crisis. So slowly we'll pass on the benefit to CDK4 inhibitors itself. So we are coming to those times. So now even if we have liver lesions, we can start CDK4 inhibitors unless we have a liver function decay. So that's where we are heading.
Fair enough. So Karthik, your thoughts on this updated overall survival published 2 days back in NEJM? Mona Lisa 2?
Yeah, I mean, pretty interesting. Mona Lisa now everywhere. Mona Lisa 2, 3, and 7 all has a OS benefit. So big boost for ribosectinic, I guess.
Yeah, yeah, I know that Mona Lisa is really, both 2, 3, 7, all the three have shown excellent overall survival benefit. So lengthy paper in NEJ, but definitely showing that significant overall survival benefit. Now considering that, we have 3 CDK4 inhibitors, Shailesh, how do you choose your CDK4 inhibitor?
Basically, sir, I don't think that there is any difference between these 3 drugs. But my personal preference is ribociclib because the initial cost is less. So that's my. Then also, I have so many patients, but they are all doing good. Abemaciclib, I had one patient who had severe diarrhea, so I am scared to use abemaciclib. So palbociclib and ribociclib, it is almost equal in terms of efficacy, I feel.
Santosh, your thoughts, which is your go-to drug and why do you use that?
I have used both palbociclib and ribociclib extensively, and we also had a clinical trial with abemaciclib. So I kind of have a take on all of them. Palbociclib, yeah, the only main, obviously, the trials have not shown OS benefit. Other problem with palbociclib is there is significant neutropenia that we face, and many times I had to go down to 75 milligram of dose for many patients because they have grade 3 neutropenia, which is not the case with ribociclib. The side effect profile is much better tolerated compared to the palbociclib. I mean, with respect to ribociclib. Hence, I switched to completely recently to ribociclib, and we in addition to that, we have the OS data to support us.
Fair enough. Aditya, do you think that the preferential inhibition of CDK4 as well as the high amount of free drug concentration makes a difference?
Not in every setting. Maybe if somebody has CNS disease or spinal disease. So I had a patient with intramedullary mets, hormone positive. In such a scenario, maybe I might have picked abemaciclib, but otherwise it doesn't make too much of a difference whether it is just a CDK4 selective or a CDK4 and a CDK6. So all of it, ultimately boils down to whether it's perimenopausal, then yes, then clear-cut ribo. If there is some CNS disease, then maybe clear-cut abema, but otherwise, all of them are almost the same. There is no choice. I think in terms, if you talk purely in terms of cost, I know academic discussion we shouldn't be, but palbociclib is slightly more, economical because Pfizer has a separate patient assistance program depending upon the income, but I don't think that should make too much of a difference in the overall picture.
Suman, your thoughts on your drug choice?
Drug choice for premenopausal, there is no question. I still go with ribociclib. Though there are new data that abema is also effective. There is the palbociclib I very seldomly use. I have burned my hands before I lost a patient neutropenia. And then regarding abemaciclib, there are very specific indication. Recently, I started a patient who had very severe osteoporosis, but still patient wanted CDK4. So abema is the only drug which can be given alone. So that patient I started abemaciclib. Other than that, most of the patients, even cost effective, I think ribociclib is the most cost effective among the 3. So most of the time it ends with ribociclib. There are very few indications which I use abemaciclib.
That's an interesting indication for abemaciclib. Karthik, your choice and why?
I think Aditya has rightly spoken. I think we should use what we are comfortable with. There is no head-to-head. There is nothing which is superior to other. And as everybody has correctly pointed, if in case there is a brain mets, maybe abema will score over others. But I think we are very comfortable using palbociclib and ribociclib because it has been there in the market since quite some time. And palbociclib, of course, because of the patient assistance program, we have given n number of palbociclips, and even though there are neutropenias, febrile neutropenia episodes are very less. I have not lost even a single patient due to palbociclib as such. So according to me, palbo and ribo both are okay with me because I've been using it since quite some time.
Yeah, my issues are with palbociclib. When we order the next lot of drugs and then we have to reduce the dosage, by the time already 125 mg has come, sometimes I get caught what to do with that. Problem with the ribociclib is I have no idea how to do this QTC reading. And problem with Abima is sometimes we end up with quite significant diarrhea, but not at all common. So do you monitor all your patients like this? What is your usual monitoring process, Shrilesh?
So we, for ribociclib, I personally probably use ribociclib. We do an ECG at first, then after 15 days we do ECG, CBC, LFT, and again after 28 days we do the same. Then after that just we do CBC and LFT. We don't usually repeat ECGs. Only 3 ECGs in the first month.
Okay, fine, fair enough. Santosh, you also do the same, or is there any change?
Yeah, I agree with Dr. Shrilesh. ECG is an additional monitoring that is required for ribociclib, and to some extent electrolytes, magnesium, these things we need to, and LFT, that is an additional requirement. We can get away by just doing CBCs for a long period of time with palbociclib.
Okay. Aditya, do you do the CD day 14 CBC, ECG and LFT, and have you changed anything till now doing that?
So I do it on day 14. We don't have such a busy practice, so I do it on day 14, but till date I have not changed in anybody.
Okay, fine. So I just reiterate that, in Mona Lisa trials, what they've shown is, yes, there are some side effects, but the discontinuation rate is very low. And interestingly, reduction of the dose does not compromise the overall survival benefit. Suman, how liberal are you in reducing the dosage? In other words, what percentage of your patients actually you do your dose reduce?
No, for ribociclib, I seldom reduce dose. For palbociclib, it's inevitable. Mostly, I reduce dose for all the patients. Ribociclib, it happens only after 5-6 months. I have reduced dose by one step for 2 patients. Otherwise, they go well with 1 week gap. 1 extra week gap will correct the neutropenia, so they go on.
Yeah, fair enough. Karthik, have you dose reduced ribociclib? If so, are you now comfortable with this study saying that it doesn't matter much?
Yeah, I have started reducing the dose much before this study, so I'm right now comfortable. So 600 mg, I feel that there are subsequent, substantial number of patients. I can tell maybe around 15% of the patients, 20% of the patients who will not tolerate this dose. I need to come down to 400. There may be LFT impairment, there may be neutropenia, but definitely yes. Palbociclib, I can tell 30 to 35% of the patients I do reduce the dose to 100 mg.
Yeah. So Santosh, your final thoughts on these Mona Lisa? Has these Mona Lisa made a different drastic change in or a paradigm shift in the way you are treating your patients?
The presence of the OS benefit, when all the other studies have also done a placebo control study, does help the cause. However, there are differences in the way the studies have been conducted, whether they've taken first line, second line, versus they've allowed chemotherapy prior to using the CDK4/6 inhibitors, etc. Just because of the tolerability, improvement in quality of life, and an effective PAP, that also helps to make a decision in favor of ribociclib when we are choosing between the CDK4/6 inhibitors.
Excellent. So if the organizers give us time, we'll just have 5 minutes on the next slides. Is it okay?
Yeah, so 5 minutes left for the session to Yeah.
So what after CDK4 inhibitor? Suman, what do you do? Patient has progressed now 1.5 years. You've given her a good quality of life. Now patient has progressive disease. What do you do?
PIK3 testing I do.
Okay. Have you continued CDK4 inhibitors and changed the hormonal therapy ever?
So yeah, PIK3 testing. So if it's positive, I go with PIK3 inhibitor, and if negative and still patient is not fit for chemotherapy or not willing for chemotherapy, there are some trials which give abemaciclib as second line even after other CDK4 inhibitor progression. So other than that, it will be mostly end with chemotherapy.
So in the trials also you can see that patients who what is the percentage of people who receive subsequent CDK4 inhibitor? It's roughly around 20% of them. Karthik, would you use CDK4 inhibitor in second line, somebody who's progressing on one CDK4 inhibitor? If so, would you change it or would you just continue the same, because that is also an option?
I've done everything, sir. I've continued the same, changed the hormones. I've basically changed the, CDK inhibitor. But mostly what happens is it depends on how much it has progressed. If there's a gross progression, there is only 1 or 2 bone metastasis, maybe I'll retain the CDK inhibitor and change the hormone partner, because a patient would have paid from his pocket for 10 months ribociclib and I tell that, okay, stop it. Then they may be angry on me. Definitely, yes, we discuss scientifically, but I feel that I'm comfortable basically changing the hormone partner here. But if there is a gross progression, maybe everything, PIK3 is a good, if it's mutated PIK3 inhibitor and fulvestrant is a good option here.
Fair enough. Santosh, what would you do? Would you change, and what partner would you change? Would you change the CDK4 or would you change the hormonal?
I agree with Dr. Karthik to some extent, but my second choice of agent is based on the PA3CK mutation. And if it is a mutated patient, would try to convince the patient to take on alpelisib. However, otherwise would change to fulvestrant plus or minus the ribociclib, palbociclib based on the degree of progression. Though there is no hard data for this.
Yeah, there's a trial Trinity where they're trying to see whether continuation of ribo is going to help. And like how all of you have said, if you do a PIK3 testing and if it's positive, better to go with the alpelisib rather than continue the same. So Aditya, I think this has already been discussed. Ideally, we should do a testing on the biopsy specimen. If it's not available, you can do it on the blood. If blood is negative, then you need to definitely repeat it on the tumor. Is it a fair summary, Aditya, or would you change anything?
No, I agree. But at least the practical considerations would make us do the same thing.
Fair enough. Fair enough. So it is also clear that if it is positive in the blood, the response is as good as if it is positive in the tissue. So for the final slide, Karthik, what is your consideration before starting this alpelisib? What are the things you look for and what are the problems you have faced?
Sir, frankly speaking, I have not given alpelisib to any of the patients. No problems at all. So
okay.
Yeah, but I think I'm aware that if at all I'm going to give alpelisib any of the patients, maybe diarrhea, rashes, and these are the main neutropenia. So these are the things which probably I need to be aware of.
Suman, your thoughts on when you use alpelisib, what do you look for and what are the problems you have faced?
Yeah, for alpelisib, elephant in the room is glycemic control. So it's very high. Almost all 100% of patients will have a glycemic problem. So we start with doing HbA1c, fasting blood sugar, and see the glycemic control. And apart from the sugar control part of it, the other side effect profile is as good as any TKIs. So it's the same. So one thing to remember is the blood glucose levels.
Fair enough. Shrilesh, is it the same, and how comfortable are you looking after the diabetic level?
Sir, I have used only in one patient. Actually, patient progressed after letrozole plus palbociclib for more than 3 years. Then we did the PIK3CA testing in the blood. It was positive. We started on alpelisib plus fulvestrant. But the glycemic control was very horrible. It was 500, 550, and patient was very irritated because 3 years she was doing fine. Then after that, so I had to stop in between. So it is. I don't think that it's a very comfortable. Maybe because our experience may be the problem. So,
I feel experience with this drug and also experience with managing diabetes is a big problem. I think we need to get the endocrinologist into the picture immediately or as soon as possible. So I think I would end here by saying two things: that results of Mona Lisa trial clearly show significant overall and progression-free survival benefit of adding ribociclib to endocrine therapy, and it has been a paradigm shift in the way we manage metastatic breast cancer who are hormone positive. And when they progress, if patients are PIK3 positive, which is around 40% of the time, alpelisib with fulvestrant really is useful, but we have to be very careful with two things: with rashes and, more importantly, with the glycemic control. I think with that I will end. I thank all my 5 panelists for this excellent discussion. Thank the organizers for giving me this opportunity. Thanks a lot, here.